Grey zone FFR is a commonly encountered clinical scenario affecting approximately 1 in 50 patients attending the cath lab with stable angina, and we needed clarification on how to best manage these patients. This is a single-site randomized controlled trial of patients with stable angina where patients were randomized to medical therapy versus PCI with optimal medical therapy. Patients who have fractional flow reserve measurements which return a result of 0.75 to 0.80 inclusive are considered grey zone FFR. Our patients who underwent MRI scanning had a prevalence of 17% of major ischemia on stress perfusion MRI, while 25% had some evidence of detectable ischemia in the grey zone territory at risk. In terms of the symptomatic improvement of PCI in addition to OMT, we demonstrated that 2 out of 5 of the Seattle angina scores were statistically improved by PCI over that of medical therapy. There are some very important differences between the Orbita population and the grey zone FFR population. 94% of our cohort had an FFR of 0.8 or less, whereas in Orbita 29% had an FFR which was non-ischemic and greater than 0.8 and therefore less potential for improvement with PCI. In terms of medical therapy, the mean number of anti-anginals in the PCI arm of grey zone was 1.3 versus 2.9 in the placebo arm of the Orbita trial. Therefore, our study showed that with less intensive medical therapy and PCI, a greater treatment effect was achieved than that observed in the placebo arm of Orbita with intensive medical therapy. These patients are commonly encountered at the cath lab and they always present a clinical dilemma. I think patients should be evaluated on a case-by-case basis, taking into account patient factors, lesion morphology, as well as coronary physiology. It should not be binary decision-making, but certainly my preference will be towards treating these patients with PCI going forward, if technically feasible. I think a multi-centre randomised controlled trial in grey zone FFR, in order to be powered to detect differences in hard clinical endpoints, would be of great benefit, although it would be extremely difficult to execute in real life.